Dr. Timothy Olweny is not a stranger to this show. He's been here before. We've talked about health, universal health coverage, and all that is needed. Now he's been given the job to actualize what he's been talking about here from the other side. Umeongea sana. Kuja. He is the new chairman of the Social Health Authority. He's our guest. Good morning, Daktari.
Thank you and welcome.
Good morning, viewers.
Welcome to the other side.
Welcome to the authority.
Yes, you are welcome.
Yeah, this is good.
I'm welcoming you instead.
No, this is very good.
It's very good.
Like, this is good.
It's like people who announce themselves.
Yes.
Yeah.
City. Patia Daktari proverb.
What you did in Pati, thank you very much. Proverb. Okay. Our proverbs for the whole of this week are from the Republic of South Sudan. Okay. People must not be corrected at their departure time.
People must not be corrected at their departure time.
Yes.
Daktari, what's your interpretation of this one?
At that point, it's done. I mean, there's not much to say. In fact, it's the equivalent of having those WhatsApp groups when somebody passes away and they're no longer on the group and everybody's posting all these messages to that person and so on. So I think it's in terms of giving advice at the right time. It's all about timing. At that point, in fact, in African culture, I think more we have that thing of we don't necessarily talk ill or necessarily advise the dead. At that point, you just say, say good things and say goodbye.
Rest well. Yeah. Rest in peace. Kwaheri tutaonana. Daktari, the Social Health Authority. Now, of course, we know on what celebration are those in Kericho? Mashujaa.
It was Mashujaa.
Yes.
On Mashujaa Day,
20th, yes.
the president unveiled the UHC and said, from this point on, this country, we're going full UHC. And this was, of course, preceded by the passage of several laws in Parliament, and he assented to those. And one of those laws created the Social Health Authority.
Yes.
What is it?
Well, the Social Health Authority is a new body that is supposed to be the one that runs three primary funds, three funds that are supposed to take care of healthcare in terms of financing in this country. We have got the Social Health Insurance Fund, which is almost equivalent to what we have as the National Health Insurance Fund now. But there are two additional funds as well. There's a primary healthcare fund, and there's an emergency chronic and critical illness fund as well that was created. So this new body has got a wider mandate than the current NHIF that is in place at the moment. So we have got, once the bills were signed into law, they became acts. Now we got to the point where we have got regulations which are being drafted, which are supposed to operationalize those acts. And we're at the point now where we're about to go into public participation, where the public is supposed to give their views and give input in terms of what their view is of the laws, of the regulations before they are finalized, and then we implement them.
Okay. You talk about a wider mandate than NHIF.
Yes.
So it is not that this is a replacement of NHIF, but is it working in tandem, or is it the overarching body then that would then guide how NHIF would operate? How exactly is that relationship going to play out?
As per the operation of law now, NHIF actually ceases to exist. I think, you see, whenever you have, especially, and let me just give a little bit of background, whenever you've got any change in government, and especially when a government comes in with a mandate, and especially that I'd use the term overwhelming now because of representation in Parliament. It presents an opportunity for people to have transformative or radical change. Anybody who's familiar with what they call the kingdom's kingdom's framework when it comes to health policy, you know, there's a time when you've got a problem. Like in our country right now, we've got health problems in the healthcare space, in the healthcare system, and I think that is acknowledged. There are solutions policy entrepreneurs like myself. I was an exogenous policy entrepreneur in terms of I'm outside the political system, but I'm trying to effect change. And I've done that for a very long time. And then you have got the political component. So you've got a problem, you've got the solution, and you've got the political component. The political stream has to be ready. And that's why we've got a window of opportunity. That's what we have now. When there's confluence of these streams, we've got coupling, then is when you've got that policy window, and you can be able to get transformative change. In other times, we do incremental change, like even the NHIF Act over the years has been tweaked and modified, but it has not served the purpose. And that's why I think it became necessary to replace it altogether with a different body, with a wider mandate that address the problems. One of the problems we have in our country is about there's very much great emphasis on curative healthcare as opposed to preventive and promotive. This is one of the things that's raising our healthcare costs. Preventive and promotive healthcare was ignored. That's why the primary healthcare fund is there primarily. Then you've got social health insurance fund and this other fund for emergency, chronic and critical illness that concentrate on the curative. But the aim is to keep people healthy. So at the moment, once we have all these funds put together, we should be able to address the problems. I've been on this show many times before. And one of the things I had a problem with was especially the handling of emergencies in our country. Medical emergencies, Section 43(2) of our Constitution states clearly nobody shall be denied emergency treatment. However, the addressee of those rights claims is the government. The government had got an emergency medical fund. It was never operationalized. Now we have got that fund in place. So now we can have people getting emergency care. Going forward, we'll be having people getting emergency care regardless of where they go or where they get the emergency. And it's going to be paying for healthcare providers, meaning individual healthcare providers and healthcare facilities. So now we have got that emergency taken care of. Primary healthcare is at the basic level, and that starts with the CHPs, which were launched. Those are the visiting people in the homes. Then you've got level 1, level 2 and 3 facilities, dispensaries and health centers, which provide the primary healthcare. After that, you can be escalated to level 4, 5, 6, where you've got the social health insurance fund taking care of treatment. And then from that point on, if you exhaust your benefits in the social health insurance fund, you go to the emergency, chronic illness and critical fund. So in terms of, I want people to understand that these laws that have been enacted now is the product of work that has been done from 2021 when the current president and his team were still campaigning. And then now they came into government. So we've got a wide team of people who have been working on these laws, and I give a lot of credit to them because I can only imagine how much work it has taken to get to the point where you have got all these policies put in place, you get them into laws, and before we have had any policies, but they were never anchored in law. So now we've got policies, they've been anchored in law, and now we're getting to the point where we're getting to implementation.
And institutions. So directly answering Ndu's question, this authority replaces NHIF.
Replaces NHIF, but has got a wider mandate than NHIF had in the past.
Okay. When does NHIF cease to exist?
Technically, NHIF has already ceased to exist. So the Social Health Authority has already taken over. And in fact, I think the other day I was looking at the newspaper reports where one of the media houses was saying that there are mass sackings looming at NHIF. And I think that needs to be put in. I was present during that meeting with the CS Health. That was not correct interpretation of what she said. I wanted people to understand NHIF themselves have the NHIF staff. We've got a lot of good and hardworking people at NHIF. So I don't want anybody to create the impression that NHIF is being phased out because NHIF were not doing a good job and corrupt and this and so on. NHIF, anybody who is old enough to know in this country, I've been in this healthcare space for the last 30 years. NHIF in those earlier years used to pay for bed only. And it used to be rates that are minuscule. In fact, I remember once
3,000.
I remember once, not even 3,000. It used to be as low as a few hundred shillings, depending on what level of facility you went. And I remember once a patient telling me, NHIF are paying for my bed when they were being discharged from hospital. They said, I don't need them to pay for my bed. I've got a bed at home. I want them to pay for the healthcare. That is where we came from. So NHIF over the years, it's an institution that has transformed and has also done a lot. So let us also put things in perspective. Even for me, I'll be honest with you, I've had relatives who had got cancer, and NHIF was instrumental in being able to help us fund their chemotherapy, their radiotherapy, and all manner. It's a lot of good things that have come out of NHIF. So we're not saying we're throwing out NHIF because it's bad. We're transforming it because the time has come for us to move on to something better. I think that's the way to put it.
So it ceased to exist. So what do we have now?
The Social Health Authority.
So the people who work and paid by NHIF, are they automatically now employed by the authority?
No. NHIF is, and there's a transition clause that says NHIF is being wound down over a period of a year. So the main thing that is left for NHIF is to wind down the operations. The Social Health Authority is going to be a new organization. We're going to set up a new structure because I've said the mandate is different. So you can't just copy and paste what's at NHIF and put it at the SHA. But what is going to happen is that we are going to have a full new organizational structure.
Yeah.
We're going to have people applying, and the people at NHIF, and I want to emphasize this again, have got the option to apply, and it is even specifically stated that they will be given priority. Because at the end of the day, they have got the kind of experience that we are going to need. So as long as you are qualified for the job and you're fit for the purpose we require, they will be given priority.
But is there a guarantee?
But you must apply.
You must
Yes,
apply.
you must apply.
It is not automatic.
Because it's a different body. It's a different organization.
So there's
when
no
this one-
guarantee,
This
yeah.
one that is being wound up,
Yes.
what's happening? Are we declaring redundancies? What exactly is the technical issue happening here?
I am still to get full legal interpretation in terms of what that is going to involve. So that is something that is ongoing.
Okay.
But the simple understanding is it is being wound down. Everybody is leaving NHIF. So either you leave and transition to the Social Health Authority, or you opt to retire, or you are absorbed into public service. Those are the
Okay.
options that they have.
Okay.
Me as a contributor, where is my money going? Is it dying with this thing?
Immediately that signing happened, your money is with Social Health Authority. Yes.
Okay. So there's also a lot of hardware that goes along with this fund. Your card, what you've then been able to access, where you are up to date. Are we looking then at a fluid transition of all of this? Are there going to be new, are there going to be new cards issued? Do you continue using the old one? Will there be a break in transmission? I think these are the questions that a lot of folks are asking right now. Public participation is what you had mentioned will be happening now. And then when it has then been, fully established, will there be a break? Will there be a time where you will not be able to access 1, 2, 3? Or are we just looking at fluidity in terms of motion?
Between the two boards of the SHA and for NHIF, we're working on ensuring that we have got a seamless transition so that service is not interrupted. That is our priority. So we want to make sure that service provision continues. However, for example, in terms of registration, you're going to have to register with SHA afresh, because even the model in which contributions are being funded and so on is different. Originally, NHIF was based on contributors. Now we've got a model that's based on households. So even the data that is being collected is different. So there's going to be a 90-day period when we want people to be able to come and register with SHA. And even you remember the contribution levels are also going to be different. So we cannot immediately say that if you're an NHIF member, you're automatically an SHA member. You have got to be able to get registered with the SHIF, Social Health Insurance Fund. But that process, we want to do it in such a way that service is not interrupted in terms of providing care to member beneficiaries of the schemes.
Okay, because you would understand that there would be folks who would be nervous, people who are getting weekly care, for example, and would have to present an NHIF card today, and are not going to be able to wait for your 90 days kind of thing. Those are the questions, and what kind of guarantee or surety then can you give them when they need to access this care that they have been accessing for the last, however long?
Just to re-emphasize that is one of our highest priorities, to make sure that service provision is not interrupted in the process of this transition. Yes.
So when do we expect this transition to end? So we're already saying, technically, the Social Health Authority is the one in place now. NHIF is in the process of winding down.
Yes.
Right? Winding up. Which is what?
Down or up? Wind up, wind down.
It has been wound up.
Oh, wound up, it's going. Wound down, it's finishing.
Finishing.
Yes.
Okay, sawa. From January next year, are we starting to operate under the Social Health Authority? Under Social Health Authority, we have the 3 funds. Or are we still operating under the one NHI fund until this NHI thing goes?
We're operating under the Social Health Authority.
So from January, we'll have Primary Healthcare Fund in operation.
Yes.
We'll have the Social Health Insurance Fund
in operation.
Emergency and Critical Care Chronic in operation.
Yes.
Okay.
Hiya.
So it means, therefore, or I hope it does, that the offices that NHIF occupied before are the same offices that will be occupied by
Social Health Authority.
Yes. All the assets are owned by the Social Health Authority.
Very good.
Yes. So
Must I wait for the bell to be rung for me to go and register, or can I just go there and register today?
we would have to have the systems in place. We will let you know.
Okay.
So those are things we'll formally. You are aware also that we have got a current legal hindrance that is in place, which is content of which I cannot discuss. But I'm hoping that is overcome and it doesn't hinder these plans that we have.
Okay.
Yes.
To operationalize these laws, we need regulations.
Yes.
Okay. Where are the regulations?
The regulations were published a few days ago, and so now we're at that point where we're supposed to go to public participation. We're giving you time to be able to look at them, and then hopefully, if there are no legal hurdles, we go ahead and go to public participation. We get your views, and that is the point in time. And I know they've generated a lot of discussion, and it's one of those that is, we as the board, especially once we met and looked at the regulations, we said we'll put it out there, wait for the feedback, see what Kenyans say.
So among the sticky issues in the regulations, of course, is the contribution.
Yes.
And this is where now we are moving into the 2.75%
Yes.
Contribution,
Yes.
moving away from the other one.
Yes.
Do we have to wait for the regulations to go through public participation, to go through parliamentary conversation, to be gazetted as regulations before we start doing these contributions?
Yes. Because if, for example, that number changes, that number potentially could change, isn't it?
Yes.
Based on what the public happens, public participation.
Yes.
So this is a stage where we're listening to people. We want to hear what their views are, and based on the feedback, I'm sure there'll be some tweaking of those regulations to some extent to mirror what input we have gotten from the public.
What's the target timeline for that?
The timeline is very tight because we're supposed to have public participation should occur for 2 weeks. Yes.
So, of course, now the other side is the conversation about the 2.75.
Yes.
When this was going through Parliament and, the discussion, we're going to now introduce this extra contribution to NHIF. It was then NHIF.
Yes.
To our healthcare. The basic principle is to introduce equity for all. The other principle is to look at how do you take care of the indigents. The other one is to also see, should we have a cap? So there was a conversation about putting a cap to the 2.75, that it will not go into 2.75 of a million. It will be there, at least there'll be some higher ceiling. And then there's dropping from 500 to 300. Do these new regulations address that? Are they carrying the same message, or are there changes in the regulation?
At the moment, the regulations say it's going to be 2.75% for those in salaried employment, 2.75% of your gross monthly pay. For those who are not in salaried employment, it's going to be 2.75% of your household income, and that is going to be determined via a means testing instrument which is deployed. So it's going to vary for different people. At the moment, there is no cap.
So there's no cap.
At the moment, there's no cap.
Why are the draft regulations removing the cap?
That I'm not too clear as to why. I can say why the draft regulations are then, like I've said, these are proposals. So at the end of the day, we're waiting to hear feedback. But you must remember, in terms of just being able to make it equitable in certain ways, the principles of social health insurance. Those who are young pay for those who are old. Those who are able pay for this. So those who are young pay for those. That's how it works. But so at the end of the day, it's a discussion that we're going to listen to the feedback that comes. If, for example, nobody complains and says that we don't have a problem with the cap, we'll leave the cap out. Because at the end of the day, what we want to be able to get is sufficient resources to run. You must remember, this is a very ambitious health proposal here. So we have got various targets which we want in terms of being able to raise to be able to actualize these proposals. So at the end of the day, there are targets, and we run into, for example, out of pocket expenditure was assessed to be to the tune of our total health expenditure in the country, about 550 billion annually. Out of pocket expenditure was about 150 billion shillings. That is not acceptable. Because these are the reasons why I'm saying we want to have these discussions coming from the knowledge that we're not necessarily in a good place. Something needs to change. So it's not that people are just changing things for the sake of changing them. We're changing them to make them better. But of course, there are going to be sometimes I keep saying with insurance, I know that a lot of the skepticism here is insurance is about delivering on a promise.
Yes.
It's about saying that you have contributed the X amount of money to this fund, and the day when you need me, I'll be there for you. It's very difficult to reassure somebody when you've not been there for them because you're new, isn't it? But even with NHIF, when the proposals came, you remember NHIF, there was a time when people started paying a little, contributions were increased.
Yep.
The benefits also increased, and there's a time when actually there's a rush of people now trying to get healthcare, get health insurance. Unfortunately, and this is one of the things that we're trying to cure. They're trying to cure. I know there's also been a discussion about why the contributions for people in non-salary employment is annual as opposed to monthly like everybody else. But what people are trying to cure is because of this principle of adverse selection, where people would only go and pay for health insurance when they know they need it.
Yeah.
Yes.
All right. And then the moment they get the service, they stop. So that is not sustainable, because that level of erratic contribution is not money that you can plan on. So those are some of the things that are being done and that were put in these laws to cure the health problems we have.
Dr. Timothy Olweny, the chairman of the Social Health Authority. It's in place to implement the universal health coverage. It's also in place to take over from NHIF, which is being wound down within the next 1 year. So you've said the staff at NHIF will be required to apply to SHA. They may opt not to apply to SHA and opt to either retire or be absorbed in other sectors of public service here in Sawa, and all those things will happen. In the meantime, we, the contributors to NHIF, what are we doing? Are we, at the end of this month, December, where is our money going?
It's going to the Social Health Authority technically,
Okay.
because yes.
But so the regulations, the draft regulations have been published to go through public participation up to the point of being gazetted. Do you think at the end of this month we will start making the new contributions with the 2.75% requirement?
That's what I'm saying. The only, if everything goes according to plan, like I said, at the moment, we have got a legal encumbrance there. So we cannot speak with certainty, but that was the plan.
Okay.
Yes.
The plan was by the end of this month, we're already moving to 2.75 because they'll have been gazetted and all.
Yes, and then we're able to implement all the funds like they're supposed to be, and we move on to SHA and SHIF and the other funds.
Okay. The bane of NHIF over the last few years, maybe quite a number of them, is to have enough in terms of funds. Getting everybody essentially on the health grid and saying contribute at whatever level, whether it be formal or informal. If it was a split bane, the other side of it would have been corruption. Do we see that this will take on a totally different face just because we've changed the name, or because we've grown the mandate essentially of the authority? So those two things happen, dogged by corruption year on year on year, not really able to know where money was going, whether there was investments in certain areas, and then the questions were, why then were we not able to deliver healthcare, as it were? On the other side is saying you have a group of 40 odd million people who would essentially at some point need healthcare, but we don't have 40 or so million people who then are making a monthly contribution in order for that healthcare to be delivered. So that's on the table. We did hear the CS say the other day that, you know what, this thing is mandatory. You don't deliver, in terms of you don't contribute, we deny you a number of services. Is it? CT doesn't like that very much.
No, I dislike it immensely.
Yeah. So what are we looking at here? Because it's true on one end, if you're saying that you're going to deliver social health, you need to have the contributions, you need to have the money to be able to do so. And then to make it mandatory with some kind of punitive on that other side is a whole other kettle of fish. But will the authority be able to shake off the things that dogged NHIF for years and then guarantee that this health that we are talking about will be delivered, whether it is at first level, second level, third level, whether it is preventive, promotive, whether it is whatever it is, with this mandatory contribution, will it happen in a way that it has unfortunately never happened before?
I know there have been a lot of governance issues in NHIF over the years. And one of the solutions I think that if you look at this current plan is about, first of all, segregating, unbundling certain functions and segregating them. in terms of being able to enhance efficiency, accountability, and so on. Because NHIF was handling the entire spectrum of all the activities in that value chain, if you want to call it a value chain.
Yeah.
And so at the moment we have got different bodies. For example, we already have the three different funds. We have got a claims management office in terms of determining who pays the benefit, what the rate of benefits. We've got a benefits package and tariffs advisory panel that has been set up that is independent. We have got part of the issue in terms of claims administration. There's an option to be able to outsource them. I know that has also been controversial, but they have tried to look for solutions in terms of being able to improve governance within the organization. Now, the good thing, like I've said, this is not the same organization. It is being built anew. So it's an opportunity for us to do things differently.
To start afresh.
To do things differently. And that's why I'm saying in terms of an organization structure, and we put in sufficient checks and balances to ensure we have to learn from the past. And that's what we are hopeful. Now, in terms of the contributions in the mandatory nature, I think I alluded to it. We have got to have a significant pool. Universal has to be universal. There's no two ways about it. And at the end of the day, if you are going to be a Kenyan citizen and you're going to benefit from these funds, you must remember now, the primary healthcare fund is funded by the exchequer. The same with the emergency and critical illness fund.
Yes.
And that's why you're saying this one, you don't even necessarily need to be a paid up member to benefit from the primary healthcare fund. That's funded by exchequer. SHIF technically is the one that is a members fund, the one in the middle. So what we want to ensure is that clients are able to get this entire spectrum of benefits. But for you to be able to get it, for example, I know for you to benefit even from the primary healthcare fund, you have to register with the social health insurance fund. The reason is simple. We need to be able to know, first of all, and I think basic things like, are you even a Kenyan citizen? Isn't it? Because the moment you introduce, for example, funding at this level, you can have people, especially at our borders, coming from other countries and coming to access our healthcare services for free. So at the very least, we want you to register. You not necessarily have to be a paid up member, but the moment now you need higher level care at level 4, 5, 6 in terms of facilities, in terms of social health, now you need to be a paid up member. And also the same for benefiting from the critical and chronic illness. So the only thing that you will benefit from is emergency care if you are a registered member but not paid up. Now that is the spirit. I know the issue of making it mandatory and the manner in which it is being implemented has rubbed some people the wrong way, right? But I want people to propose options that are viable for us to be able to get people to still register in the numbers that are required to be able to sustain the scheme.
Have CT say, what should you do to me if I don't pay, instead of denying me government services?
You see, I would have assumed that more flies are caught with honey than with vinegar. You see, if you focus on the benefits and how they are going to be provided, and you take the time and bother to ensure that it's understood, the threat is not necessary. No one is going to move away from something that they can see is definitely beneficial. But at the same time, if you then lace it to the threat, then suddenly somebody says, why are you threatening me exactly? Because the moment someone says, other services will not be provided for you, that's a threat. So you're saying, wait, you've now moved from what the contribution of the fund, you then move into the realm of now looking at my fundamental rights, and you're telling me you want to deny me those rights because of this. So then I ask them, is this thing really a benefit? And then I start, questions that need not arise then begin to arise from just the way that matter is approached.
CT, I'm in agreement to the extent that it is not about, and by the way, first of all, NHIF is also mandatory as we speak. It is not that it is not. It is actually mandatory. It's just that people have not been contributing towards it for various reasons, but also in terms of enforcement, it's not been enforced. I am in agreement to the extent that it must be about
the benefits
and the service delivery.
Yeah.
That is going to attract the public to be able to enroll for this new scheme.
Yeah.
And that takes time because we have to start and implement, and people see the benefits. And I'm saying even historically, even from NHIF, that is where we came from. The enrollment went up the moment the benefits package came in. The only challenge that we have is we can't have erratic contributions to the scheme. It's not going to make it sustainable. So, and sustainability is a key issue when it comes to this fund. So that is, we'll have to figure out ways, but this is still subject to public participation. I'm sure people will listen to the views of the public and take them into account by the time the final regulations are out.
You know, it's a tricky position you find yourself in, Dr. Ari, because what SHIA is offering is something that anyone who understands the health issues in this country would have said this is long overdue. Long overdue. Something that has a broad spectrum approach to healthcare needs and demands in the country. Now, the communication about it, and this is where the tricky bit comes in, it can't be easy, okay? However, if I leave that aside, what dogged NHIF for the longest time was reportedly what would be presented as a collusion between healthcare facilities and people who work within NHIF to defraud the organization, where claims are made where there's very little evidence to show that whatever healthcare was required was actually provided for. What are the safeguards that SHIA is going to put in place to ensure that what dogged NHIF for the longest time is actually eliminated and it's no longer the case?
I think it's mainly in terms of the process that have been put in place. And if you look at the digitization alone that is going to be involved in terms of management of the entire claims process, it is going to be digitized, it's going to be transparent, it's supposed to be more efficient, it's more accountable. So that's one of the main things, by the way, that makes a difference in this new process. And even the registration process that you're going to see is in terms of being able to register the members, the issue of biometrics, and so on. So I think that's why I want to reassure people that there's significant thought that has gone into trying to fix the problems that were there in the past to ensure we don't go back to that place. Because the amount of funds, by the way, that were being sent even to NHIF itself would have been able to deliver much greater benefit if we didn't have all the leakage. In addition to that, you will find that in the Act now it is stipulated that actually the administrative costs of this new body cannot exceed 5%. So we even have, in terms of operational efficiency, there are benchmarks which have been put there and safeguards.
5% of what?
5% of the gross
total contributions.
Yes. So there are limitations in terms of what we can be spent. And that's why the process have to be very efficient. The other thing which I know I have talked about, and that's why the other day I saw somebody saying the person appointed was a harsh critic of NHIF, and can he be able to? My criticism was constructive, and it always has been. It is not just an issue of criticizing for the sake of it. It was criticism to be able to make NHIF better, because NHIF had got massive potential and was going to be able to change the lives of so many people in this country. And that's the reason, one of the reasons why I even accepted to be in this position. Because at the end of the day, it is one of those things where we have a moment where we can be able to transform healthcare delivery in this country in a manner that has not been done in a very long time.
Okay.
You know, Dr. Harry, I am in agreement with you. This SHIA thing, the 2.7%, I personally have no problem with it at all. Even if you had said 5%, I would still not have a problem with it because of what it promises. We had a CES for land sitting exactly where you're sitting when they were digitalizing the land ministry. And we asked, we understand what you're saying. You're trying to convince us it's foolproof. And then we ventured to say, you do know that we are in the country of Kenya, okay? and you do know that at some point there's a human element to this entire processes. That human element is what actually dents the guarantees. Right now, we've had cases we've discussed here of issues to do with land, and where the problem has arisen is that somebody tinkered with that process, and suddenly documents that were supposed to be sacrosanct were no longer sacrosanct because it was tinkered with. Digitalization, wonderful. Automation, wonderful. These things are wonderful. Healthcare, in my opinion, is so critical that one cannot afford to have a misstep. Because with a misstep, somebody dies. Something wasn't done when it should have been done. Some care wasn't taken when it should have been taken. Somebody dies. Good thing is you are a medical doctor. So I can't be telling you something you know far better than I do. How will we ensure that this fund actually works? I can see when you're saying people need to reapply for their jobs, it's usually a good sign. You're telling someone, you know, this thing is not what you had before. This is new. And because it's new, this is what we're going to do. But a digitalized system, yes. What else? What are the security measures are we going to put in place to ensure this thing actually works, and that the contributions that are made are safeguarded, and they actually achieve what they were purposed to achieve?
Like I said, one of the things that we have is, first of all, we must have the right team in place. Because like you've said, it's all about people still operate systems and processes and so on are still manned by people. We must have the right team. First of all, we must have the right organizational structure. We must have the right people in place. There must be, I think in the past, one of the things that has not been there is significant penalties for any breaches of what is procedure. And in the past, you have found, for example, I agree with CT that all the fraud that has occurred in the past, for example, cannot be done by a healthcare provider on their own.
No.
It has to be done in collusion with somebody else on the other side. It's like the issue of bribes and corruption, whether it's the police or whichever, it takes two to tango. And that is one of the things that there has not been significant penalty in terms, even when these monies that are so-called lost monies. Right now, you can see the penalties that have been put in the new act are actually extremely stiff. And I'm looking forward to them being stiff and they are being enforced so that it acts as a deterrent to that kind of behavior going forward. So these are the things that I'm saying, the amount of leakage. By the way, in the Kenya Kwanza manifesto, by the way, this was actually a budget neutral item in terms of the amount of money that already was even being collected in the past. If it was in a resource-constrained environment like ours, we have to be very resourceful about how we deploy those resources, but it must be done in a manner with integrity. And that's why I want to assure people that the team that I'm optimistic the team we're going to have in place is going to execute this with discipline.
Dr. Olweny, could you talk to what this will present vis-a-vis the private health insurance that a lot of people have gone for? Does this then now mean with the plans that are in place, because they are ambitious, but I can see the situation whereby if delivered in the way in which you envision, that could actually do something very good for healthcare provision in the country, with universal health coverage taken into consideration. Would people then be able to drop their private insurance?
I'd say depending on the amount of resources that are going to be deployed, the resources are going to determine what benefits we can deliver and to what extent. So depending on the resources that are going to be deployed, and that is an issue of debate, like I said, after the regulations, if, for example, the rate goes down, then the amount of money that is projected to be collected will diminish. The benefits also have to be shrunk to be in tandem with that. However, private insurance, people still have the option of being able to get private insurance. And private insurance will be there to top up in the event that you don't have the benefits that you have, the maximum benefit that you want to get. So you must realize the restrictions. For example, in terms of going for treatment out of the country, giving a social health insurance scheme, we're going to have to limit and make sure that it's absolutely necessary for you to go for treatment out of the country using public funds. So it cannot be that you're going to wake up and say, I was traveling, I'm in the US and now I've got these things, so SHA should pay. So at the end of the day, those are the things that private insurance is going to do. Eventually, I know, especially with the level of interest this is going to generate, there might be, for example, some queues, especially for elective procedures. You might decide that, no, I don't want to wait, let my private insurance pay for this. So those are the options. So private insurance still has a key role to play in terms of healthcare delivery. It's just that it's going to possibly change. Yes.
SHA will have primarily two major sources of money.
Yes.
One is members' contributions.
Yes.
Mandatory, so citizen contributions.
Yes.
The other one is citizens' contribution through taxes.
Yes.
So the National Treasury releasing money on time to take care of the primary health care and emergencies and critical care. It's important that this money is released on time.
Yes.
We have the history of government and the National Treasury and delayed disbursement. What will you do? I can see you'll deny me services. The law says you'll deny me services, the government will deny me services if I don't contribute on time. What will you do to the government when it doesn't release money on time for you to actualize UHC?
If you look at the new regulations that were published, you will find that it actually says that the government now and the county governments the same are supposed to deduct it at source and are supposed to deliver it. So that is one of the mechanisms that has been put in place to ensure there are no delays in terms of remittance of funds to the social health insurance.
What does that mean?
So it means literally that they are not getting the option of delaying in terms of at the point when the salary is released, it's released at the same time.
Please explain. So we have the local dispensary or health center.
Yes.
I go to the local dispensary or health center.
Yes.
How is that money released?
To the local dispensary. The local dispensaries are being funded through the primary healthcare fund. Then you remember there's also another bill called the Facility Improvement fund.
Yes.
And that the intention there was to be able to ring fence all funds that are generated from healthcare to be able to stay there.
Yeah.
So in terms of funding, and we are hoping in terms of funding of the facilities, in terms of supplies, they're not going to have the option of sending this to for example, the counties and then asking for this money back. The money is supposed to be with them, and therefore it keeps revolving. And this is going to be able to improve especially the health commodity supply, because that has been a challenge. A lot of the time, if you're waiting for money centrally and it comes in an erratic manner, you're not able to plan accordingly.
Yeah.
So they've got money that they're able to maintain their supply. So we're looking to
But that's all dependent on if the money came on time in the first place.
Yeah.
SHA is going to manage the primary healthcare fund.
Yes.
Right?
Yes.
Which means that SHA will receive money from the National Treasury,
Yes.
from the Exchequer,
Yes.
into this fund, and then in turn, you're the one who's paying for my service at my local dispensary.
Yes.
So for that to happen, SHA has to receive money on time
Yes.
from the National Treasury.
Yes.
Now explain to me what deduction at source, how it plays here then.
In other words, we are removing those things that would give National Treasury the option of sending this money to the different people who are paying people's salaries, for example. This is coming out direct to SHA as opposed to being disbursed together with the other funds.
Oh, but boss, money has been coming out direct from National Treasury to county government, and then for services. That National Treasury to county government has been getting delays. Part of the problem. So I'm asking, how will you make sure that you do not suffer the same delays as we see with counties?
You see,
As we've seen with the NHIF previously.
remember, here we're talking about contributions from county staff and national government officers. I hope that is clear. And all the contributions we're saying are going direct.
Dr.
Yes.
We understand, because this money that goes to the county comes from something called tax, which we all pay, and it's still delayed. You see, it's the same wananchi who contribute to and the same. You see, we are not picking a quarrel with the national government and its process of disbursing. We are looking at the seriousness and the critical nature of this service that you're superintending, and we're looking at what problems arise from delays, because we've seen, even within the healthcare. Yes, so now
the cost of delay here is way too high.
It's profound. So now we're saying we've got this ambitious project.
And we'll be looking at Dr. Olweny and say, Sasa huyu jamani,
Huyu vipi tena?
Sema itakuwa, yeah.
Well, let's just say that the extent we have gone is we have got it in the regulations. And I'm hoping that it's going to be implemented to the letter in the manner it is there in the regulations. Yes.
Can we be prescriptive and suggest?
Final message to Kenyans. In 20 seconds, Dr. Ari.
Let's just say here we've got a healthcare system where we've got the challenges are clearly delineated. The intentions are noble. The solutions are bespoke, they're ideologically aligned, and they're coherent. We've got an intention to have disciplined execution. Let's give us an opportunity to be able to implement it.
Let's give it a try. Thank you very much.
This is the Situation Room, the only way to start your day.